أعتقد صار الوقت مناسب الآن. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody to the last session in the first episode and first competition in iTeach program. Of course, we are delighted to welcome all professors, panelists, and would like to thank them very much for their generous time. And of course, we are welcoming as well the 8 speakers, and we will start. I already gave the instructions to the speakers, but again, a brief introduction. Every speaker has 12 minutes of presentation, followed by 5 minutes for discussion. 2 panelists will discuss with the speaker, and the aim of the discussion is to probe how deep the knowledge of the speaker in his topic or her topic, and in addition to probe the ability of discussion. So let us start. Speaker number one will be Dr. Faiz. He will talk about approach to clinical refraction. الأستاذ الدكتور محمود شتاوي جزاه الله خيرا. He is with us now, and we are waiting for الأستاذة الدكتورة ميرفت شبراوي to join us as well to discuss with you. So you can share your screen, Dr. فايز لو سمحت. Can you share your screen, Dr. Faiz?
I am trying to share my screen. Okay now?
Yes, we can see it.
Okay.
يلا نبدأ بسم الله.
أسعد الله مساءكم جميعا. Good evening. My name is Dr. Faiz Al-Sharif. I'm an ophthalmology specialist from Amman, Jordan. It's nice to meet you, everyone, especially Dr. Mazen Sinjab and the guest speakers. My talk today is approach to clinical refraction. Now, in approach to clinical refraction, we start with brief history, including the age, occupation, and symptoms. And we start by examining the visual acuity. Also important to include the following exam cover-uncover test for the distance and the near point of convergence, motility. Also, we have to check the patient complaint. Is it headache, eye strain, or uncomfortable vision? Now, the first part of clinical refraction is the objective, which is the retinoscopy. The benefits of the retinoscopy is that we can use it to examine infants and young children. Also, we can examine people with special needs. Also, we can check the clarity of the reflex to detect any irregularities of the cornea or any opacities in the medium. So there are 2 techniques for the retinoscopy using the strict retinoscopy. The first one is neutralization with the spherocylindrical trial lens. And the other method is to neutralize with 2 spherical trial lenses. Also, another name called for the 2 spherical trial lens method is the cross retinoscopy. So the steps in retinoscopy is to sit in front of the patient about a distance of arm's length, about 67 centimeters, and in a dim room. And when we approach the right eye, we should use the retinol with the right eye and look to the patient to his right eye, and same for the left eye. The patient is asked to look at a target 6 meters away. Usually, we can use a Snellen acuity chart or a green light from the duochrome test to relax the accommodation. This is a picture of how retinoscopy is done. So the three main steps of the retinoscopy is to start with motion, add power to neutralize the reflex, and then finally subtract working distance at the end. And this is an example of neutralizing a patient with retinoscopy. We can use loose trial lenses, and this patient has with motion reflex. So we try to add the plus lenses. By adding +1, the reflex will become more apparent. +2, it will become more broader, and +3, it will be neutralized, so that we are reaching the target of the objective refraction. Now, regarding the other part of the clinical refraction is the subjective refraction. That's a process of steps performed in proper order to get an accurate glass prescription for any patient, is to check the sphere power after doing the retinoscopy. And then we move to check the cylinder axis and power using the Jackson cross cylinder, and then refining the sphere power and using the +0.75 diopter sphere lens blur test. And finally, we will conclude our test by binocular balance, which I will talk briefly now. Now, the principles of refraction is to keep the accommodation relaxed during the exam. The target of the prescription is to give the maximum plus or the minimum minus. That enables the patient to see visual acuity 6.6. And if the patient has an isometropia or high degrees of ametropia more than 4, +4 or -4 diopter, we should check the back vertex distance for the glasses. Now, to avoid over minus, we have to start with the positive sphere lens. And we should hold the positive sphere lens in front of the patient long enough to allow the accommodation to relax. And we ask the patient 3 questions. Is it better? Is it worse? Or is it just the same? And if the patient says it is better to see with this plus addition, we add around 1/4 to half diopter to the clinical prescription of the patient. But if he said it's worse, we stop and we switch to the minus lens. Now, one trick for the minus lens is that we should put it briefly for the patient, not for long duration, in order not to provoke the accommodation. And we ask 2 questions also for the patient. Is it better or is it just smaller and blacker? And if the patient said it is better, then we add -0.25 diopter sphere if this is what we are examining the patient. But if he said it's just smaller or blacker, we don't add a minus lens. We keep his prescription as it is. Now, regarding the Jackson cross cylinder technique, it's we have 2 aims. The first one is to check the axis of the astigmatic lens prescription. And the second important part is to check the cylindrical power. So we adjust the sphere value with the cylinder found objectively in place so that the circle of least confusion is placed on the retina. And we should have, for example, we can give the patient a target like a duochrome test or a C chart to have the black target equal in clarity between red and green background on the duochrome test. Okay, and we should hold steady the Jackson cross cylinder in front of the patient and flip quickly. Now, this picture exemplifies the importance of the circle of least confusion to be placed properly. When we put the patient and ask him about the Jackson cross cylinder, one image will be blurred for the patient, and the other image will be more clear. So that's when we do the modification. Now, more notes about the Jackson cross cylinder. Check the axis, then power, then recheck the axis. Ask the patient, is the target rounder, sharper, clearer with which position. And if the visual acuity of the patient is 0.8 or better, we use plus minus 0.25 cross cylinder. We have two types of cross cylinder. And if the patient has visual acuity less than 0.8, we use that plus minus 0.5 cross cylinder. And for each addition of minus 0.5 cylinder, we should modify the sphere prescription to the opposite side with the half value. Now, the best vision sphere is to refine the sphere power of the Jackson cross cylinder by adjusting sphere for best visual acuity. And we should check duochrome test to make sure that patient sees the equal clarity black target on duochrome test. Now, the plus 0.75 blur test is we intentionally blur the vision of the patient after examining the Jackson cross, and we should compare the amount of blur. If the patient was 6'6" and then he becomes 6'9", then we will modify by adding plus 0.25 diopter. But if the patient blurs significantly below than 6'12" or worse, we should check our refraction and modify it. Now, the last step is the binocular balance. And we mean that the purpose of the binocular balance is not to balance the visual acuity of the patient, but to balance the state of accommodation between the two eyes. During monocular refraction, different state of relaxation of accommodation may occur between the two eyes. So our aim is to allow both eyes to have retinal image simultaneously in focus. Note that imbalanced correction often leads to asthenopia because of unstable accommodation. And we have to keep in mind that the best corrected visual acuity should almost be the same in both eyes to perform the binocular balance. And we couldn't apply it to a patient that is amblyopic or has suppression, or there is big difference in visual acuity between the two eyes. And the most common method used is the Humphreys fogging method. And we use a plus 0.75 diopter spherical lens to fog the left eye. And as a result of that, central vision will be suspended, but the pericentral and peripheral vision are maintained. And we direct the patient to view the right eye best visual acuity line, perform the best vision sphere in the right eye until the acuity we gain the maximum plus or minimum minus, and we repeat the test for the left eye. Now, another final test is the duochrome test, fogging the left eye with plus 0.75 diopter sphere, direct right eye to the duochrome test, and light should be dimmed. Check the patient has a preference toward the red or the green background, and repeat it for the left eye. The right and the left eye should have equal preferences at the end. The take-home message is that clinical refraction is an art. Practice makes perfect. Retinoscopy is an essential objective test that every ophthalmologist should learn and practice at the clinic. Always start with visual acuity, and refining your final prescription is essential before prescribing glasses. These are my references. Thank you very much.
Thank you very much, Dr. Faiz, for being on time. Now we open the discussion. Ustaz Dr. Mahmoud Shtawi. Unmute yourself, Ustazna. Unmute, please.
Okay. Can you hear me now?
Yes, I can hear you.
Yeah, okay. Dr. Faiz, it was a nice presentation, but I just want to ask you, how often do you use cross-cylinder, Jackson cross-cylinder for your patient? How often? Do you do it with every patient, or what exactly?
Okay, in our facility, I work at the Shami Eye Center. We have optometrists that help us in the patients, but some patients who are complaining, frequently changing their glasses without any benefit and complaining of asthenopia, we use Jackson cross-cylinder to refine their astigmatic correction.
So you don't use it as a routine? Also, dichrom test, how often do you use? So what's the rule of autorefraction? How often do you do autorefraction in your clinic?
In my practice, we use the autoref as a baseline. And we compare our retinoscopy and the subjective refinement with the autoref. But the final prescription is based on the subjective refraction.
Do you do it as a routine or just for certain cases?
The autoref in our facility is done as a routine, but we don't rely on it alone to give the patient his prescription.
So I don't know exactly what you mean, but do you mean every patient that you do is you have to do a refraction and you do a routine cross-cylinder and dichrome test, or you just for certain ages or certain people or certain indication?
It's not for every patient, but the patients who follow up for the prescription of their glasses and are not comfortable with their recent glasses, we use the autoref for them.
Do you do okay? Do you do your refraction for patient? Suppose if a patient is 65 years old and he wants a reading glasses and different glasses, how do you proceed?
Yes, we use the Jagger point test, and using the trial frame, we estimate the age of the patient, and according to the age, we can start by adding, for example, if the patient is 60-year-old, we can start with roughly with +2 sphere, and let the patient check the best corrected line, and we modify accordingly. How do
you assess your back vertex distance? Manually, not with auto refraction.
we use a ruler, and we depend. There is on the trial frame lens. There is a measurement that measures the distance between the cornea and the prescription or the trial lens. Okay,
thank you.
Thank you, sir.
Thank you, Ustaz Dr. Mahmoud Shtewi.
Thank you, Faiz, for your presentation.
Yes, Ustaz Dr. Mervat, please.
أهلا بيك يا فايز. I'm very happy to listen to you. والحقيقة إن حد جميل كده زيك بيقدم بشكل جميل، فأنا سعيدة جدا بيك يا فايز وبشكرك. وطبعا أستاذ دكتور محمود شيشاوي يعني هو قام بالأسئلة كلها. الحقيقة مش عايزة أطيل عليك، بس أنا ليا سؤال بسيط خالص يا دكتور فايز. هل أنت بتعمل تailoring للكلينيكال ريفراكشن دوت لكل بيشنت، ولا هو حاجة standardized عندك هو كده apply على كله؟
Thank you for the question. It is a standard approach for every patient in our practice, because I think this is the ideal way to give a correct clinical prescription for the patient, that he can become comfortable with his vision on the long term. We think of the long term, and the follow-ups, we make sure that the patient is comfortable with his new prescription.
Okay, great. Thank you very much.
Okay, thank you very much, Dr. Faiz. Thank you, Dr.
Most welcome. You are most welcome. Thank you very much.
Thank you for Ustaz Mahmoud Shtewi and Ustaz Dr. Mervat Shabrawi for the discussion, and Dr. Faiz as well. Now, just a comment. I know that Ustaz Dr. Mahmoud Shtewi is an examiner in Glasgow, so all of these questions are targeted for the refraction, which is something very important for every ophthalmologist. So I know the background of his questions, excellent questions, and by his questions, he is encouraging every ophthalmologist to know how to do refraction and not to depend on the autoref, because the autoref just gives an idea, and the keystone of refraction is the subjective, followed by the cycloplegic in some cases, and followed by the PMT in order to get the best refraction for the patient, especially if we are planning for refractive surgery. So we can now move to the second speaker. The second speaker will be Dr. Ashraf. He is going to talk about biometry is still your call. I find that Ustaz Dr. Brahim Adawi will discuss with you, and I will be discussing with you as well.
So the screen is shared right now. My name is Ashraf Zaid. I'm an anterior segment surgeon based in Egypt. This is just a quick recap regarding the biometry, which is something really important, and everyone should be doing it properly. So I have no financial interest in this presentation. The first, regarding the history of the IOLs, the first one was implanted by Harrod. It was an anterior chamber BMMA IOL. It had a biometry error of 20 diopters, and then Fyodorov invented the Vergen's formula. In 1970s, the A-scan started to be more accurate and more reliable. And then in 1922, Gernert and Zorkendorfer, they said that the average biometry for any human being is plus 23.70 diopter. This was slightly unethical, and it had a lot of errors, but it was convenient for a lot of people at that time. He depended on this formula, in which he used the net corneal power, the axial length, the effective lens position, and the desired refraction postoperative, and the vertex distance. And since 1982, we had an ongoing evolving theoretic formulas. So the biometric components are four main components: the K readings, the axial length, the media type, and the postoperative effective lens position. Regarding the K readings, the cornea is assumed to be a perfect spherical mirror with fixed antero to posterior corneal curvature ratio, in which the posterior is 1.2 millimeters steeper. The surface power formula is D equals N2 minus N1 divided by R, in which the D is the diopteric power of the eye, the N is the refractive index ratio, the R is the radius of curvature of the central 3 millimeter corneal zone in millimeters, and this is something important. The most commonly used devices for calculating the K readings are the autokeratometry, and here it measures only the 3 millimeter central zone. The IOL Master, it has 6 hexagonal points that gets the K readings from. The lens star system, which has 32 points and 2 circles. The Argus source OCT, which adds the central corneal thickness, the pupil diameter, and the anti-chamber angles. And the corneal topography, which is essential in premium IOLs, as well as toric, trifocal, and the multifocal IOLs. 1 millimeter error in the K readings equals 0.9 diopteric error in biometry. The second thing is the axial length. I'm going to speak about two main groups here: the ultrasound, which is the contact A-scan biometry, in which distance equals time by velocity. Here we can see that this goes for the A-scan and the B-scan. The probe, it has, when you see the echoes of the ultrasound waves that you see, the first one is the anterior corneal surface, the second one posterior, and then the third one anterior lens surface and posterior lens surface, and then the retina and sclera and the choroid. 1 millimeter compression in this method results in an error of 2.5 in average eye, 1.75 in long eyes, and 3.75 in short eyes. And the non-contact biometry. The principle is using light instead of sound, reaching retinal pigment epithelium of the fovea, which is the endpoint of the actual optical system. Two widely used devices are the IOL Master and Lens Star. Also, Aladdin from Topcon is very nice. It's non-contact, easy and fast, and more accurate in special situations like silicone filled or staphyloma. But it has limited use in dense opacities and needs fixation because it depends on light. This is a quick comparison between the IOL Master and the Lens Star system. The main cut point here is that the Lens Star system can measure the corneal thickness and can measure the lens thickness, which is essential for some equations that we are going to talk about. Regarding the IOL Master, which is the most commonly used device in the world, it has a lot of info regarding axial length, K1 and 2, and spherical equivalent standard deviation, and it gives you the actual corneal cylinder at which meridian. It states the eye status, which is phakic or aphakic or whatever. You can put in the printout your commonly used IOLs, and you can say what's your target refraction and how will you assess it. And also it gives you multiple formulas like Haig's 1 or whatever. Now, regarding the formulas and effective lens position, the first generation started before the 1980s and had an A constant of a 4 millimeter anterior chamber IOL, because they only did intracapsular cataract extraction at that time, and implanted an anterior chamber IOL, hence came the name A constant. It was developed by Sander, Ritzlaff, and Kraft, which is known as SRK. The power is A, which is the A constant, minus 2.5 the length, minus 0.9 the K readings. It works well for average eyes, but it's less accurate for long and short eyes. Second generation formula, in the 80s, Binkhorst used the axial length as a single variable predictor of the biometry. The modified A constant was based on the axial length. The power is A1, which is the modified A constant, minus 2.5 the length, minus 0.9 the K readings, and this is almost obsolete. Although some people use it in pediatric calculation. Third generation regression formulas means regression that they did a lot of cases and then they made an analysis of these cases and see how they can correct the biometry that they had. In the 1982-88, two variables were added, not only the anterior, the axial length, but also the K readings as variables in the biometry equation. Holiday 1 is good, very good for axial length from 14 to 26, SRKT above 26, and Hofer Q below 22. In the fourth generation formulas in 1995, Olsen et al. Added two more variables, the preoperative anterior chamber depth and the lens thickness. The equations that depend on the are considered as fourth generation formulas are the Holiday 2, Haigis, and Haigis L. New generation formulas, which is the most common used formula in most of the developed countries right now, is the Barrett Universal 2 formula. It has a lot of data that you can put inside: name, patient name, doctor name, and the ID. It has the lens factor that you know, or the A constant, or a personalized constant if you did a lot of work to do your own personalized constant. And you have the axial length, K readings, optical anterior chamber depth, and the refraction on both eyes to compare. And then there are some optional stuff that you can add, like the white to white and the lens thickness. This is a table that I got from the iWiki website regarding the recommendations of American Academy in the choice of formula. In regular cases, if the axial length is below 20, you can use the Holiday 2 or the Hofer Q. From 20 to 22 is Hofer Q, 20 to 24.5 is SRKT, and so on. I will post this table later on. And we have special formulas, like for the thickness calculator or any or toric calculator or any other IOL rather than the thickness. It gives you, and you put the data that they ask for, especially the surgically induced astigmatism of the patient, of the surgeon, and you can post where you want your incision to be, and the steep and flat meridian, and you can include the posterior corneal astigmatism as well. Biometry, they depend on the axial length, the method you must state if it's optical or emergent, and the A constant of the IOL, and then you select your preferences, and it gives you a printout that can help you a lot regarding the toric implantation. There is not just these calculators. There is a lot of calculators, as you can see by just posting IOL calculator on Google. You can find a lot of calculators. So for special situations, silicon felt, it has an issue that refractive index is higher than vitreous in silicon, because so the ultrasound travels slower. The standard velocity measurement can lead to 8 millimeter error. It has difficulty with ultrasound measurement for the same reason. And the total axial length should be this number, which we can state that you can just calculate your axial length as usual, and then multiply by 2 over 3. And in high axial myopia, it has the issue of lower rigidity and the probable presence of staphyloma. IOL master is preferable than a scan, and the formula you must choose it formally to be aligned with the axial length. And minus lenses should be available prior to the surgery, whether foldable or none. In the axial hypermetropia, also the IOL master is preferred. The Hofer Q formula is most accurate. Here I'm speaking about axial myopia, which can differ and can make the effective lens position change a lot. It can bring your IOL to the front if it's hypermetrope, and to the back if it's myope. Regarding sulcus implantation, the effective lens position changes from the back into the sulcus. If it's above 22, you decrease it by 1.5 diopter. If it's from 17 to 28, you decrease it by only 1. From 9 to 17, decrease it by 0.5. If it's below 0.9, you don't change it. And post-refractive, all of these formulas were based that the cornea is a virgin cornea. While the corneal refractive surgeries change the corneal refractive state, increasing the risk of refractive surprises. And also that the cornea, when it's measured in the normal situation, it's measured only on the 3 millimeter circle zone. So if you got the pentacam or whatever, if you got the Placido disc printout, make sure that you are measuring your key readings on the 3 millimeter circle zone. HGSL, it's available in almost all of the devices. You can use it for myopia or hypermetropia with very predictable outcome. Pediatric cataract, the challenge is growing axial length, age, and bilaterality, and associated anomaly. Usually you aim for undercorrection to develop the near vision properly, and because this is the most need of the pediatric age. The take-home message is biometry is still your goal. You must know this table. It's very nice regarding the recommendation of the American Academy. And thank you very much.
Thank you very much, Doctor, for the nice presentation. And we now open the discussion. Ustaz Dr. Ibrahim Adawi, please.
Thank you very much, Dr. Ashraf, for this nice presentation. And first, I would like to ask you, what do you mean by biometry is still your goal?
What?
What do you mean by the title of the presentation?
It's still your goal because there is a lot of surgeons who can just make anyone make the biometry for them, and they go to the OR, they don't take a look at the biometry, they say, okay, they tell him, dear surgeon, your IOL is 22 or something. He doesn't care about the spherical equivalent, he doesn't care about the needs of the patient, he doesn't care about anything, he doesn't make sure that everything is...
You mean that the surgeon must look carefully for the biometry before entering the operating theater?
Exactly.
What do you prefer, the IOL master, which is very common and all of us know, and lens star? Lens star, I don't use it before. Which is better, and which is there any advantage between the two devices?
I guess the only advantage that the lens star system has is the measurement of the central cornea thickness and also the lens thickness, and they can measure
the central thickness and the lens thickness.
Lens thickness, and that's
this is the only advantage.
The only difference. But the Zeiss IOL Master
very important.
The IOL Master is more friendly, user friendly. The lens star takes a lot of time, so someone
much more easier IOL Master. In a special situation, in the near future, we will face many cases who did refractive surgery in the past, and it is very important to make a good formula and a good instrument for measuring the IOL power for those patients. Is the type of refractive surgery affect the biometry, which is PRK, LASIK, etc.? Or
I think the factors that matter a lot is the optical zone and the ablation zone of the refractive procedure happened on, the preoperative refraction and the postoperative refraction later on. These what changes the actual power of the cornea, and we must always make sure that we are measuring only the 3 millimeter central zone of the cornea, because this is the area that has the pupil in, and this is the area in which the patient should be seeing properly. Of course, the issue of having a lot of already present issue of having a lot of patients who underwent refractive procedures. Also, the RK era made a lot of impact regarding how to measure the speeds alike cornea, and with all of the surprises. But I think in having all of those patients with the studies evolving regarding them, regression formulas specifically designed for the refractive patients will emerge sooner or later.
Is the type of refractive surgery SMILE or PRK or ordinary LASIK, does it affect?
I don't think it affects. What affects if it's myopia or hypermetropia, according to the zone that was treated on.
Okay, thank you. Thank you.
You're welcome.
Now, of course, I have to correct some concepts. Regarding the IOL Master, it does measure as well the central corneal thickness and the lens thickness. It's not only the lens star. This is one point. The other point, actually, I'm surprised that the table you presented is taken from the American Academy website, because the information are outdated. So they should be updated, because a lot of new formulas are much better. And I'm going now to mention those formulas just in case anyone would like to use them or should use them, okay? Let's say for the, let's say the normal eye, which is not axial and not not high axial or not low axial, or not after refractive surgery, so the usual eye or ordinary eye, we can use the best formulas are now the EVO, Kane, and Hofer QST. These are the best, and they can be found on the ESCRS IOL calculator. It's online. Now we come to the long eyes, high axial. The best formula is the Hofer QST, all right? Not the SRKT. And if you want to use the SRKT, you must not use it if K reading is less than 42 or more than 46, because it will give errors. Now, for the short eyes, the best is Hofer QST as well. Now, if it is after refractive surgery, whatever, myopia, hypermetropia, SMILE, LASIK, or PRK, the best is Olsen ray tracing. If you don't have it, Barrett through K formula. This is the best. So as we see, these information, of course, I'm not talking about your presentation. I'm talking about the information that the American Academy is still presenting on their website. This is very strange and very odd, actually. Now, I want to ask you one question before we finalize. You mentioned that the K reading, the topography is better to take the K reading in case of the trifocal and toric. So which K reading do you mean?
I mean that you should take the central 3 mm K readings on the central 3 mm zone of the cornea. And to make sure it's not about I wasn't speaking about that. It's a must to do a corneal topography for them to make sure that they don't have any corneal abnormalities regarding the multifocal. Like if the patient has keratoconus and he wasn't diagnosed in his life, or this is what I meant. I didn't mean that you should take the K readings solely from the corneal topography in that. No, this is not the rule. And
great.
And I just want to add.
Let me give you this information then. You have to take it from the topography, actually. You have to take it from the topography because in premium lenses, the trifocal, multifocal, and toric lenses, you have to take the total corneal refractive power, the TCRP, which takes into consideration the anterior and posterior surfaces. Otherwise, you will get into undercorrection or overcorrection. So corneal tomography is not only to rule out ectasia or whatever ectatic diseases, but as well to take the K reading from the topography in premium lenses. And the topography is important as well in case of post-myopic or hyperopic or astigmatic treatment on the cornea, because we need to take the EKR, the equivalent K reading from holiday report. And then we put it into the formula. So just in case we don't have those formulas on our machine, we want to use the calculators, we have to consider either the EKR if it is irregular cornea, and even in keratoconus, or the TCRP if it is regular, but we want to put the premium. So thank you very much, Doctor. And actually, it was a good presentation. So let's move to the third speaker. The third speaker will be, you are with us? Dr. Sarah. She will talk about the single pass. Wa alaikum salam, single pass for true pupilloplasty. Yes,
Yeah. Start sharing screen.
Yes, please. I think Dr. Nancy is not with us, but Dr. Ahmed Mustafa is with us.
Assalamu alaikum. Bismillahirrahmanirrahim.
Good
evening. Good evening, respected professors and doctors. First of all, I would like to thank all doctors here for giving us your time and attention. It's my pleasure to present my presentation. I'm Dr. Sarah Sultan, General Ophthalmologist, and I'm from Yemen. I will talk about the single pass for Pupilloplasty, SFT. It's an intraocular surgical method for pupillary reconstruction. A common goal from it is restoration of the shape of the pupillary aperture, aiming for a better quality of vision. When the pupil is dilated and fixed, it can compromise the quality of vision. The patient complaining of glare, photophobia, and visual distortion, and these symptoms may interfere with the patient's daily activity. Additionally, pupil and iris defect causes the iris diaphragm to be floppy and less rigid, and can lead to anterior and/or posterior synechia, which can cause secondary increase in intraocular pressure. So, in 2017, Dr. Ammar Agarwal tried something different. He demonstrates a new technique for pupil reconstruction. It's a single pass for pupilloplasty. In this topic, I will talk in brief about clinical applications, advantages, considerations, and technique. Clinical application in Arts-Zavalia syndrome. Arts-Zavalia syndrome is a persistent pupillary dilation along with raised intraocular pressure. As SFT pulls the iris tissue here, it allows the aqueous to move freely to trabecular meshwork, breaking the formation of peripheral anterior synechia, inhibiting the mechanical blockage, and prevent secondary and prevent angle closure glaucoma. It also effective in a selected cases of angle closure glaucoma. Dr. Ammar Agarwal performed SFT in combination with lens extraction. He found that the procedure opened the angle, released the associated pus, and secured the iris centrally to prevent recurrence of the pus. Dr. Agarwal also explained the node placement. If peripheral anterior synechia are observed around more than 270 degrees of pupillary margin, carry out 6 points of retraction. That means 3 nodes are performed to construct the pupil. But if peripheral anterior synechia is less than 270 degrees, you only need 4 points of retraction. That means 2 nodes are sufficient to construct the pupil. In pre-descent endothelial keratoplasty, an important consideration in endothelial keratoplasty is to prevent and minimize endothelial cell loss. In cases with endothelial decompensation and pupillary deformities, pupilloplasty is performed to compartmentalize the eye into anterior chamber and posterior chamber, acting as a diaphragm to prevent escape of the air into the vitreous cavity. This acts as maintenance effective air tamponade in the anterior chamber, prevent posterior dislocation of the graft, and facilitate graft adhesion. Also, in PKB, to prevent post-operative complication in some cases of floppy iris that is expected to adhere to the peripheral edge of the corneal graft, causing peripheral anterior synechia. Pinhole pupilloplasty pierces the distorted peripheral rays arising from irregular corneal surface, and it also canalizes the ray of the light through the center of the pupil. This enhances depth of the focus, preventing patient from glare and photophobic image. Advantage: less intraoperative manipulation, thereby less inflammation. SFT doesn't comprise a true node formation. It involves an approximation loop with no securing loop. This leads to the formation of helical structure like this, which is self-locking mechanism. It almost parallel to the surface of the iris, reducing the bulk into the anterior chamber. It's beneficial for patients undergo endothelial keratoplasty. Fundus visualization: patient treated with pupilloplasty still can undergo mydriasis, but pupillary dilation in SFT-treated eye is less than that untreated eyes. If the patient needs retinal treatment, the retinal surgeon can snip the SFT suture and reopen the pupil, or use YAG laser to undo the pupilloplasty. Considerations: SFT cannot be performed in phakic eye, and that lensectomy should be done in the same surgical session. If the patient has fixed pupillary dilation with chronic angle closure in uveitis, SFT may chronically inflame the iris. In general, the surgeon should be careful to avoid over-tightening the helical knot, which could tear the iris tissue. Technique. This is the proximal part where we enter, and this is the distal part where we exit. With a forceps, catch the iris and pull it to the center. With a straight needle, 9-0 or 10-0 proline, pass to the proximal part of the iris. From the other side, throw a clear corneal incision, 26 gauge needle, engage the distal part, and then railroad technique is performed. The straight needle is dug into the lumen of 26 gauge needle, both needles withdrawn from the distal part. With Sinjab hook, create a loop. And this is 4 throws. This is a helical loop sliding inside the anterior chamber. The two ends of the sutures are pulled away from each other. With microscissor, finally cut the end. This is a case of traumatic cataract with dilated pupil. The surgeon is Prof. Mahfoud Bamishmus. Started with incision, clip and glue, and trying to remove the synechia with Sinjab hook, capsulorhexis, and then phaco. Implantation of IOL into the bag. Start pupilloplasty. With a straight needle, 10-0 proline, engage the proximal part of the iris. Throw a clear corneal incision, 26 gauge needle, engaging the distal part. And then, railroad technique is performed. The two needles withdrawn from the distal part. With Sinjab hook, create a loop. The end of the suture is passed 4 times through the loop. And this is 4 rows. The two ends of the sutures are pulled away from each other. This approximates the two parts of the iris. And finally, cut it with microscissor. This is before the surgery, and this is after the surgery. The appropriate pupil size, the patient achieved the best visual performance here. This is another case of traumatic cataract and subluxated lens here with dilated pupil. Started with incision, trying to remove the synechia with Sinjab hook, capsulorhexis, and then lensectomy. There is a tear in the posterior capsule, so vitrectomy is done. IOL implantation, also vitrectomy, and trying to reform the shape of the iris with Sinjab hook. Start pupilloplasty with 10-0 straight needle proline, engaging the proximal part of the iris tissue that need to be approximated. Throw a paracentesis incision, 26 gauge needle is passed, and engage the distal part of the iris. The straight needle is dug into the lumen of 26 gauge needle. Both needles are withdrawn from the distal side. Create a loop with Sinjab hook and start to make 4 throws. This is the second, third, and finally the fourth. This is a helical loop sliding inside the anterior chamber to form self-locking mechanism. Cut it with microscissor and finally close the eye. This is preoperative and this is postoperative. A round, beautiful pupil with a simple procedure. Home message. SFT is an elegant, simple procedure, safe and cost-effective. Less intraoperative manipulation, less inflammation with a good outcome result. This is my references, and thank you for your attention.
Thank you very much, Dr. Sarah, for the nice presentation. Ustaz Dr. Ahmed Mustafa.
Thank you very much, Sarah, for the very nice presentation, actually. Sarah, I want to ask you what is the optimum size of the pupil?
It's depend. If we need a small pupil for a high order astigmatism, for corneal high order astigmatism, Dr. Ammar Agarwal explained that we need 1.2 or less. But if we need just the retina is clear and we need to reform just the shape of the iris, like the surgeries, as I will show you, 2 to 3 pupil size is enough. And that there is some doctors explained some method. There is a pinhole ruler or a holiday. This have 8 pinholes started with 1.5 and 2.5 and like this. We ask the patient if what's the pupil size pinhole he get in a good visual outcome, and we do like this. This is a method, but we don't use it in our clinic.
Interesting. So that what are the technical difficulties you might encounter during this procedure, Sarah? Did you do it yourself, or did just Dr. Mahfouz cases?
No, it's Dr. Mahfouz cases.
And then you just think what could be the possible technical difficulties, because you said it is simple. So I need to know how far it is simple. How could you identify things being simple or not? So what are the possible technical difficulties? Just think.
It's simple because it's simpler.
No. My question is no. My question: what are the possible technical difficulties?
Yeah, maybe that the surgeon take the needle to the cornea, and this may injure the corneal endothelium. This is some techniques.
So this is one issue. Another.
Over tightening of the helical knot may take the iris tissue to tear.
This is another okay. More difficulties.
Also, it can not be used with a phakic eye. It's just to do with pseudophakic patient.
Great, but what are the other technical difficulties? You think how much iris tissue is needed to grab to say that the suture is okay?
Yeah, we need enough tissue to approximate the tissue. We need enough tissue of the iris.
So the suture can tear away during tightening, for example. So this is one of the difficulties. Yes, and also if the needle engages the back of the corneal tunnel, as you said, it's not only the problem of damaging the endothelium, but you will find that the thread is attached to the back of the cornea, and at that time you have to cut and then make things over and over. So that, you know, again, everything, there is nothing that's very simple. We can say that it is a procedure which is doable, but it needs a lot of training. So that we cannot oversimplify things like that, because everything needs good training. Also, now if the patient has, just the question you need to think, you shouldn't have to be, you know, that having a lot of information beforehand. If the patient is having extensive peripheral angiosynechia, as the case shown by Dr. Mahfouz, and then you have released this synechia, how to make sure that this pupil will need repair or not? How to make sure of that? Because the pupil could constrict post-operatively.
Yeah, first with the forceps, when we catch the iris in the first step, we can it's inform us if there is enough tissue, iris tissue to be repaired or no, and it's inform us about the extent of pus, also peripheral anterior synechia.
Yeah, I mean, sometimes we lyse the synechia, and then we can, at the conclusion of the surgery, if we inject just intracameral myocol, and then we find that the pupil will get down, and that the pupil was dilated because of the posterior synechia. And then at that time, we may not repair the pupil. I mean, it is a decision which we need time to take. It's not that, yeah, it could be a preoperative if the pupil is dilated and fixed, and then there is no synechia. But intraoperative, if you have lots of synechia, you need to decide after lysing those synechia. Sarah, one more question. Have you heard about the reverse through pupilloplasty technique? As you are in this area, what's the reverse technique?
Reverse technique is the same technique of SFT, but we engage the pupil from the posterior, not like we do from the anterior part, from the posterior part, and the node will be posteriorly.
Interesting. So this is very good that you followed the other, that the other techniques of similar terminologies. So Sarah, I thank you very much. This was a really nice presentation. I learned a lot from this presentation myself. Thank you very much.
Thank you, Prof. Ahmed. Thank you very much.
Thank you, Ustaz Dr. Ahmed Mustafa Abdulrahman, for the nice discussion, and thanks to Sarah for the nice presentation. Speaker number 4, Dr. Hind. She will talk about brittle cornea syndrome. Dr. Hind, you are with us. Please start sharing your screen. Dr. Iyad will discuss with you, and hopefully Dr. Muhammad Al-Aqaba will join us later. Please start, Hind. We cannot hear you, Hind. Unmute yourself, please.
Can you hear me now?
Yes.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank all the professors for their valuable time and for giving us the chance to express ourselves. My name is Hind Hilal. I am Assistant Lecturer of Ophthalmology, Faculty of Medicine, Banha University, Egypt. My topic today will be about brittle cornea syndrome under the title of When You Manage, You Start the Challenge. I will start my presentation with the question of what is brittle cornea syndrome? Brittle cornea syndrome is a rare autosomal recessive connective tissue disorder with its incidence is less than 1 per million. It affects the connective tissue not only of the eyes, but also of the ear, joint, and skin, and characterized by severe corneal thinning with risk of corneal perforation either spontaneously or even with minor trauma. As a genetic disease, we have two types of brittle cornea syndrome. Type 1, due to mutation of ZNF469 gene with a change in the central corneal thickness, and type 2, due to mutation of BRDM5 gene with a change in the corneal thickness as well as in development of the retina. From the practical point of view, we clinically suspect that the case has brittle cornea syndrome. We can suspect that the case has has brittle cornea syndrome if the patient has any of the following. Thin cornea, especially if the central corneal thickness is less than 400 micron with or without rupture. History of inoculation or corneal scarring as a result of previous rupture, especially if the trauma, minor trauma. If the patient has bilateral bluish sclera, if the patient has early onset progressive keratoconus as early as the age of 2 years old and or keratoglobus, and don't forget to look for the retina as this patient may be associated with retinal detachment. Also from the practical point of view, what to do if you suspect that the patient has brittle cornea syndrome? Brittle cornea syndrome is a systemic disease, has ocular manifestation and extraocular manifestation. So the first step to look for the ocular manifestation by measurement of the central corneal thickness by anterior segment OCT or Biometry, and the second step to look for the extraocular manifestation by ENT consultation for deafness, musculoskeletal consultation for joint hypermobility, and the genetic workup to detect a gene mutation. I have a case of brittle cornea syndrome. 6-year-old child came to emergency room by his mother. His mother was complaining of sudden clouding of cornea and loss of vision in the right eye after minor trauma. When asking about the family history was negative for known eye disorder, no infection or abnormalities in pregnancy or birth, but his parents had positive consensuous marriage. On examination, as you see in the picture, the right eye saw right corneal edema with bilateral bluish sclera and bilateral corneal thinning. Refraction can't be taken on the right eye, while the left eye show high myopia and astigmatism, and this can be done and it was completely normal. This case is highly suspicious for brittle cornea syndrome. Why? What are the red flags here that made me suspect brittle cornea syndrome? The first is a sudden corneal insult with minor trauma. The second is post-consanguinity with there is a suspicion of genetic disease. The third is the presence of bilateral bluish sclera and the corneal thinning. And finally, presence of high myopia and astigmatism. So I decided to look for the extraocular manifestation. And when asking the mother reported that this child has joint hypermobility, hearing loss, and dental abnormalities. So I decided to go for the workup and look for the ocular manifestation and do the anterior segment OCT for the right eye. And in doing so, as you see in this picture, the cornea show corneal edema with multiple cysts in the cornea, and the thinning of the cornea and the thickness of the cornea after exclusion of the false high increase due to corneal edema, the thickness of the cornea not exceeding 300 microns. But this section not reveals the cause of corneal edema. So I decided to perform multiple sections in the corneas at multiple levels to look for the cause of the corneal edema, and here was the first surprise. The surprise was there was a tear in the descent membrane, as you see in the 4 sections here, and there was areas of stroma, thin layer of stroma with epithelium overlying. So this cornea is liable for perforation at any time, even spontaneously or even with minor trauma. As a systemic disease, it affects not only one eye, but also the other eye. So I decided to do anterior segment OCT for the unaffected eye. And here was the second surprise. The second eye, the corneal thickness is 189 ultra-thin cornea, not exceeding 200 micron. And this goes with the brittle cornea syndrome, where the thickness is less than 400 micron. So I decided to move for the next step. My next step was family screening as a genetic disease. So I decided to screen all the family members. There was post-consanguinity, and he had 2 brothers. One of them had normal corneal thickness with normal appearance of the sclera, and the other had blue sclera with thinning of both corneas. And this is the anterior segment OCT for the 2 brothers. I decided not only screen the brothers, but also the parents. And surprisingly, both of them had bilateral corneal thinning, and the parents of the mother has positive consanguineous match. And this is the anterior segment OCT for the father and the mother. The final step here to confirm the diagnosis is genetic workup, as is genetic disease, to confirm a mutation of the affected gene and to detect the presence of carrier. But unfortunately, genetic testing was not available, but we are seeking to be done in future. But the most important question is exclusion or inclusion of diagnosis of brittle cornea syndrome in such cases is important or not? And if the patient is confirmed to be brittle cornea syndrome, would the treatment will be different from other ectatic disease or not? The answer is yes, because the brittle cornea syndrome has a unique nature and a highly challenging disease. So let's start the challenge. There are a lot of challenges in the brittle cornea syndrome. The first challenge is prophylaxis against corneal perforation. The second, when perforation occurs, how to manage and how to stop the disease progression and how to treat the associated refractive error. And if there is associated condition like cataract and glaucoma, would the treatment will be different? Let's move to the first challenge. The first challenge is prophylactic against corneal perforation. This cornea, as you see, liable for perforation at any time, even spontaneously. So this child must use protective polycarbonate glasses, but this is unrealistic, especially in this age. You must do lifestyle modification. And some authors recommend using of IOP lowering medication, even in absence of high IOP, contact lens, although it may be risky in extremely thin cornea. But what if perforation? If perforation occurs, this is the second challenge, because perforation may be a nightmare for the surgeon, because following perforation, such cases mean the repair of these cases may be extremely difficult and sometimes impossible due to the tissue is excessively fragile. This is like suturing of the butter. This is called cheese wiring of suturing. And even if you succeed in suturing, there is risk of intraoperative perforation during suture rotation. And even if you succeed in suturing and suture rotation, there is the risk of excessive leakage post-operative due to mismatch between the donor and the recipient bed, in addition to the high risk of graft rejection and the risk of general anesthesia. In this situation, how to manage? You must modify your treatment. You must not deal with this cornea as a normal cornea. You must modify your suture technique by using 1109 suture with long suture bite in order to reduce the risk of post-operative leak. Also, there is a literature, a case have intraoperative or corneal rupture occurred during a 10 minute of rotation of suture, and this was managed by scleral patch graft. And the literature, this perforation were managed by pericardial patch graft, amniotic membrane, keratophysis, and keratoplasty. What about progression? Brittle cornea syndrome, like any ectatic disease, is progressive disease like keratoconus, treatment by crosslinking. But crosslinking used in corneas under 400 micron carry risk of significant endothelial cell toxicity. So some authors recommend using FABN technique, but unfortunately in literature, cross-linking is still controversial. Why? They reported cases even with use of FABN technique, they underwent corneal rupture. The fourth challenge is treatment of associated refractive error. This child has high myopia and astigmatism, which make him liable for amblyopia. The regular astigmatism may be difficult to treat with the spectacle, and the contact lens, as I said before, must be used in caution in this extremely thin cornea. What about glaucoma? If the patient has associated glaucoma, it will be challenged. But I have two questions first. Why glaucoma occur in these patients with brittle cornea syndrome, and why management of glaucoma in this situation become a challenging situation? The first question, why glaucoma occur? Because there is risk of developing glaucoma after penetrating keratoplasty in the early and late postoperative period. Patient with peripheral arteriosynechia has high risk of developing glaucoma. In addition, 50% of pediatric patients with fragile cornea develop glaucoma after penetrating keratoplasty. Let's move to the second question. Why glaucoma management is extremely difficult in such situation? This is in two bases. Difficulty in assessment and the difficulty in management. Difficulty in assessment due to difficulty in measuring the intraocular pressure, as this cornea has no normal biomechanics, and there is loss of scleral rigidity, and there is corneal thinning. And some methods of measuring of intraocular pressure may be traumatic to such a thin cornea and contribute to corneal perforation. What about management? You need in management of glaucoma sclera. This extremely thin sclera and the absence of reliable sclera makes the glaucoma surgeries as a nightmare for the surgeon. So some authors recommend, if you want to use a glaucoma drainage device, you can manage by using fibrin glue. You can secure the plate to the sclera by fibrin glue as a substitute for suture. And if you are planning to use cyclophotocoagulation, please adjust your energy parameters. The last challenge is the treatment of associated cataract, and this is the case report from literature who has secondary cataract after keratoplasty. They manage the situation by using the transeocorneal lensectomy. This means that they have placement of the trocar not anterior to the graft host junction to avoid the placement of the trocar in the fragile cornea and avoid perforation. So, take home message, brittle cornea syndrome should be suspected in every child with early onset keratoconus, extremely thin cornea, and the corneal perforation, either spontaneous or minor trauma. Once you suspect brittle cornea syndrome, systemic workup should be done to search for extraocular manifestation. Screening of the family member should be done to detect any patient with subtle disease, and the mainstay of treatment is prevention of corneal perforation. As you see, it's a challenging situation, so you must modify your treatment due to unique nature of the disease. And finally, caution should be taken in every time you deal with such a fragile cornea, even in IOP measurement, contact lens application, and suturing. And here are my references, and thank you.
Thank you very much, Dr. Hind, for the nice presentation. Dr. Iyad, of course, we are delighted when we see our colleagues from Palestine, Dr. Iyad, with us. So, Dr. Iyad, please.
شكرا دكتور. شكرا دكتورة هند. محاضرة رائعة. موضوع كتير مهم.
English, Dr. Iyad.
Oh, English, yes. Thank you, Dr. Hind. It's a great presentation and a very important topic. Although these patients are, as you mentioned in your talk, are extremely rare, but unfortunately, every cornea specialist in our world will once or a year or more face these cases. Still, during your presentation, you mentioned many methods to repair the cornea or to deal with the corneal rupture, and other surgical methods like keratoprosthesis, and all these methods still, are not sure they will work or not work in such cases. By chance, I had to deal with such case just last week, and as you showed in your case report, we had to finally, we couldn't close the cornea, and we had to do a corneal graft. When just just a note, when you do corneal graft for these patients, for these eyes, you have to do the largest possible graft. And so you can, and you suture the, practically you suture the graft to the limbus. And as you mentioned, this also increases the chance of, yes. So before going to grafts and so, do you know other methods, surgical methods, surgical techniques to just to cover, to close the cornea, to suture the cornea, to prevent this cheese wiring?
I know in the literature they said that there is epikeratoplasty. They use epikeratoplasty as a living contact lens for covering the cornea. In keratoglobus, they mentioned that in these cases has keratoglobus, so you can use the anterior lamellar keratoplasty with peripheral interstromal tucking. You use large graft and you use peripheral interstromal tucking for enhancement of the limbus.
Yeah.
This is the ways I have read.
There is one method that I learned and I practiced it in 2 cases and successfully worked. Before starting suturing the cornea in such cases, you go for something called mattress suture. Mattress suture, you take a large suture from limbus to limbus to adjust the edges of the wound. And if you create such suture, so when you suture the cornea tissue, you don't have traction on the edges, much less traction. And these techniques worked at least twice in my practice. So I wanted to share this with you, but thank you. It was great. Again, the prognosis in these cases is not certain, and it's guarded, but we have to do everything. And as you mentioned in your talk, it's a nightmare cases. I don't know, I'm not a glaucoma specialist, but again, you are right, glaucoma management also and glaucoma evaluation in these IOP pressure, intraocular pressure, and it's difficult and challenging. And thank you very much for your presentation. You did very well. I also got benefits from your talk. Thank you.
Thank you so much.
Thank you, Dr. Iyad, and thank you, Dr. Hind. Now, I would like to invite speaker number 5, Dr. Muhammad Mahmoud. He will talk about some measurements related to white. الأستاذ الدكتورة سوزان قبطان and الأستاذ الدكتور وسام شحادة will discuss with you.
So you hear me now?
Yes.
Okay. First, I would like to thank the panelists for their time and giving us the chance to present tonight. My name is Muhammad Mahmoud Harras, and I will talk. And I'm an ophthalmology specialist at the Ministry of Health of Egypt. I will talk about the influence of horizontal corneal diameter on corneal tomography and Pellin Ambrosio enhanced ectasia display of pentacam corneal tomography. The cornea is the principal refractive surface of the eye, which is responsible for approximately 2/3 of the optical power of the eye. Corneal diameter differ between individuals and between populations. For example, it's much higher in European and Iranian population than the Chinese population. First, I would like to ask a question. What is the role of corneal diameter in refractive surgery? Of course, we all know that it's required for haptic size calculation in angle-supported IOLs, anterior chamber and phakic IOL implantation. It is also required for that CTR size calculation. It is also required, as my colleague mentioned earlier, it is required for some of fourth generation formulas like the Pellet universal formula. What is the corneal diameter rule in laser vision correction? That's why we did this study. It was done in Tanta University in Egypt. It's about the influence of horizontal diameter on corneal tomography and Pupilloplasty display. It was a retrospective, non-randomized, non-comparative study, included the preoperative pentacam images of 126 patients or 252 eyes that underwent laser vision correction. The patient admissions, the inclusion criteria are both genders and also the age from 20 to 30 years old. At this age have stable refraction, and also this age comes more for refractive surgery. Exclusion criteria are keratoconus patients, including permafrost keratoconus and previous refractive surgery, and presence of any corneal pathology, dystrophies, or scar. The selected cases were chosen without any risk factor for ectasia according to ectasia risk scoring system and BS3 system that was created by Professor Mazen Sinjab. The correlation were performed between the corneal diameter and these parameters, the anterior K readings and the posterior K readings, the anterior astigmatism and the posterior astigmatism, and sinus location, DF, DB, DT, DA, DB, and D. And these are the Pupilloplasty enhanced ectasia display parameters. And let me remind the audience about the Pupilloplasty enhanced ectasia display. This display was created by Professor Michael Pennell and Professor Renato Ambrosio Jr. It's a comprehensive map for screening patients for ectasia. The display summarizes the corneal data into 5 differential parameters that denote the standard deviation from mean of normative data. For example, the DF is the deviation of front elevation, the DB is the deviation of back elevation, the DT is the deviation of sinus points, the DA is the deviation of the arc max, the DB is the deviation of bachymetric progression. They are all color coded. When it's suspicious, it's yellow. When it's pathologic, it's red. There is also the final D, which is a single parameter that reads all the corneal readings of all parameters. In one of the previous talks of Dr. Mazen Sinjab on YouTube, he mentions that the false positive of the Pupilloplasty display include large angle kappa, misalignment, scars, and corneal pathologies. The aim of our work was to study the influence of horizontal diameter on corneal tomography and Pupilloplasty display results, and the results was surprising. For example, analysis between the white diameter and anterior K reading showed a negative correlation. So small cornea was associated with high anterior K reading. Analysis between the white diameter and the posterior K mean showed a negative correlation. So small cornea was associated with high posterior K reading. The curve is here, it looks like positive, but the numbers are in minus. Analysis between the white diameter and Kmax showed a negative correlation. So small cornea was associated with high Kmax readings. Analysis between the thinnest location and the diameter showed also a negative correlation. So small cornea was associated with high bachymetry at thinnest location. Statistical analysis between the bad indices and the various parameters, especially if those are the white diameter. So we found that small cornea was associated with high DB and DB and D and low DT values. Multivariate regression analysis between bad indices and or dependent and previous indices and various parameters showed a significant correlation with the diameter and K mean with the DB. And also the DT also show correlation with the sinus location only. The DB show correlation, statistically significant correlation with the K mean posterior, sinus location, and the K mean. And the final D showed statistically significant correlation with the K mean and sinus location and the K mean. Small corneal diameter was associated with high DB and D, sinus location, Kmax, posterior K readings, and anterior K readings. Let's assess this case together. As a pentacam image, we found that K mean is 43, front specification is okay. Bachymetry at sinus location is above 500. The Kmax is 46. The small diameter here was 10.8, which is a small diameter. When we found the bad display of the Pupilloplasty display, we see that the DB is color-coded red. The only explanation found to this case is the small corneal diameter. Another case also, the K-mean is 43, the quality specification is okay, sinus location above 500, K-max is 45, white diameter was 11.4, which is relatively small diameter. When we see the bad display here, we find that EB and the final V is color-coded yellow. Also, the explanation is here the small corneal diameter. We discussed our results with a lot of studies that were done in the last 2 or 3 years. Most of them are Chinese. As we mentioned earlier, that all the population of Chinese have a small diameter. So we found the same results. Conclusion: corneal diameter influence corneal curvature and biometry. Small diameter generally affects the Brittle and pieces and can give a false impression of corneal ectasia. Small diameter was associated with high dB, regardless of other pieces, and also with high dB and D and low DT. This is due to disparity in curvature and biometry between individuals with small corneas and normal population. The recommendations are that clinicians need to consider corneal diameter when evaluating a patient for refractive surgery or diagnosing keratoconus, especially patients with small cornea. Thank you.
Thank you very much, Dr. Mohammed Mahmoud. First of all, I would like to congratulate you for this amazing study. Actually, it is very impressive. I observed what you said, but my observation was only for the K reading. I found that there is a correlation between small diameter and high K reading, but now you made it reality in correlation as well with other parameters. So many congratulations. Have you published this in any journal?
Not yet.
I would advise you to do so very quickly, even in any journal, in order to get the credit, because based on your study, there will be more studies in the future in order to modify the parameters based on the white-to-white. Maybe the normative data will be changed, the cutoff values will be changed, taking into consideration the white-to-white. So try your best to publish it even in any local journal as soon as possible. Now we will open the discussion. Ustaz Dr. Suzanne Quttan, Ustaz Dr. Wissam Shahada. So ladies first, Ustaz Dr. Suzanne.
Assalamu alaikum. Dr. Mahmoud, thank you for your nice presentation. Just as said Ustad Mazen, it's a great work. فعليا I notice in pediatric, because I'm a pediatric ophthalmologist, I notice in pediatric because they are the white-to-white and the K reading. We found the small white-to-white reading with a higher K reading. But we can't do the topography for the babies. So this will explain, your study will explain what we already see. But the drawback in your study, one thing, it is not, there was no control or there was no comparison. Maybe if you can take another sample and to compare it with other for comparison, because as you say, we are taking the normative data, yes?
Yes.
The population, different ethnicity in Iran, and in where you said else, they took it in Iran and in Chinese and in European population. Yes, these are reading. So this reading is the start to represent Egyptian populations. Yes.
Yes.
To make it يعني حتى نخليها مثل ما نقول إنه to make it a standard to be taken for future studies, maybe you need either a larger number or we need to compare it. But it was great. I enjoyed your presentation. Good luck. Thank you very much.
Thank you. Thank you.
Thank you, Dr. Suzanne. الأستاذ دكتور وسام.
السلام عليكم.
وعليكم السلام.
Dr. Mahmoud, I do agree that the topic and the subject you've chosen is really difficult one and full of controversies. So given all these challenges, I think you've done very, very well in the presentation. Congratulations.
Thank you.
Me as both a glaucoma and cornea specialist, I think the white-to-white measurement is of great importance, and I think there is a lot to learn about it in the near future. Your study is really impressive, and Badum Soti to Dr. Sinjab that there is much to learn about it, and some of our concepts that we know about the normal values might change according to the corneal diameters. Now, given all these things, let's get some benefit from this crucial measurement. I've seen that significant number of the attendees are of our junior staff. Now, tell us about simple steps, practical steps. How do you do your white-to-white measurement in calculating the phakic IOL sizing, particularly ICL sizing?
There is manual measurements like calipers, also the topographers and the tomographers. They also calculate the white-to-white diameter, and also the IOL master calculates the white-to-white diameter. The anterior segment OCT also calculates the white-to-white diameter.
Can I ask you, Dr. Mahmoud, what do you do in your clinic when you face a patient that is considered a good candidate for ICL, for example? What do you do on daily practical way of measuring the white-to-white caliber?
My name is Dr. Muhammad first.
I'm truly sorry, I read it Mahmoud.
It's okay. Actually, I depend on pentacam, white-to-white measurement.
Okay. Is that the only measurement you take?
Actually,
we
yes,
are trying to learn here. That's fine if you answer yes.
Actually, yes, it's nearly perfect measurement, but sometimes when we take the ICL measurements, there is a lot of differences in at the same patient in the same pentacam device, so it's not 100% accurate. But we try to take one more shot, more than one shot to take accurate measurement.
So why do you bother very much to get a very accurate white-to-white measurement in ICL sizing? What's your concerns?
Actually, large or small ICL can cause many problems to the patient, starting with the vault size and also the size, which will make the ICL circulate in its place. A lot of problems that can occur when you take inappropriate white-to-white diameter to the ICL.
That's exactly the point. That's what I'm trying to emphasize here. That's probably the single most important measurement in ICL calculations. Everything is important, no question about it, but probably white-to-white is the most crucial one, because if you end up with an inaccurate reading for white-to-white, you will end up with significantly disastrous complications like pupillary block, endothelial loss, cataracts, rotation of the ICL, especially if it's a toric. So this is the measurement where you need to spend some time. And I do actually take more than one measurement, especially if I get some sort of significant difference between measurements. There is some nice literature recently published actually about comparison of different tools for the white-to-white. As you said, the IOLmaster 700, the Orbiscan 2, the Pentacam, in addition to the manual caliber ones. And you will be surprised that there is significant difference between those tools. And in certain patients, they cannot be changed or used interchangeably because of the significant difference. So the message, my message, and that I would like to pass through your great presentation is that white-to-white is a crucial measurement. If you don't size it well, you might end up with significant complications. Thank you, Dr. Muhammad. Congratulations.
Thank you, doctor.
Thank you, Ustaz Dr. Wissam, for the nice discussion and additions. I would like just to comment here that the IOL master and the optical devices like the lens star, they magnify the white to white, they overestimate. So we must not depend on them. The best two tools are the autoref, the autokeratorefractometer, if it measures the white to white, and if you have any topographer using Placido and has the the ability to adjust manually, so you can adjust it on the topography itself. You compare both, and if there is more than 0.2 millimeters difference, you have to use a third measurement in order to be sure about that. So thank you very much again, Dr. Muhammad Mahmoud. And now speaker number 6, Dr. Reem, will talk about herpes keratitis. The panelists will discuss with you, Ustaz Dr. Yahya Salah and Dr. Muhammad Al-Aqaba. So would you please start?
Okay. I will start sharing my screen.
We can see your.
Is my screen shared, please?
Yes. Start, please.
Yeah. Good evening. I would like first to thank all the professors that they gave us from their precious time. So thank you in advance. In the battlefield of eye disease, we face many enemies with different ways of causing morbidity to the eye. Some of them might even end in loss of vision and blindness. And among those enemies with frank and obvious straightforward diagnosis, we might find that some are hidden, waiting for the chance to attack, like a crouching soldier. But sometimes if we focused on little details, we might notice them. And this is how I named my presentation today. It's the IOP, the gun barrel of the crouching soldier we shouldn't fail to notice. My name is Reem Al-Faqih. I'm a general ophthalmologist from Yemen. At first, we all know the corneal disease, especially corneal opacity, is the 5th leading cause of blindness worldwide, with infective keratitis being on the top of list of ocular morbidity. The viral keratitis is the leading corneal infection in the developed countries. In our developing countries, it's still preceded by bacterial and fungal infection, but viral keratitis is still a very important entity, with herpes being the major player in the act. With a seropositivity of 19% above the age of 60, the statistics show that 10 million have herpetic eye disease, with 1.5 million of yearly incidence, 40,000 new cases of severe visual impairment or blindness each year, putting in mind that many parts of the world are still under-resourced. So meeting the herpes, it's a member of a family called the Herpes viridae family, which is a double-stranded DNA viruses with specific pathogenicity towards humans, with an important character that they have, which is latency. What do we mean by latency? It's to remain dormant in a tissue, waiting for later reactivation. They are specifically neurotropic. We mean by that, the latency is in the neural tissue.
Dr. Reem, we cannot hear you. Dr. Reem? We cannot hear you, Dr. Reem.
Dr. Mazen?
Yes.
Okay, I will stop the video.
Yes.
Okay. As I have said, the herpes is a member of family herpes viridia, which is a double-stranded DNA viruses with specific pathogenicity towards humans, with an important character of latency, which is to remain dormant in a tissue. They are specifically neurotropic. We mean by that they remain dormant in neural tissue, the trigeminal ganglia for orbital infection. In the recent years, the concept of corneal latency has been described. It's not 100% scientifically proved until now, even though many evidences could lead to it. It could explain why the cornea, among all the tissues of the eye, is the most susceptible tissue to herpetic infection. The phases that the infection goes in starts with the primary infection, which might be subtle and could be unnoticed, could range from simple blepharitis to simple blepharoconjunctivitis. Then it would go in a state of latency, and when any stress would occur, a secondary infection and recurrence would occur. And this is the main concern of our topic today. Why do we care so much about recurrence? Because with each recurrence, the severity of the inflammation itself would increase. Other tissue involvement might be found, like iritis, trabeculitis. Secondary complications as secondary open-angle glaucoma may appear, and the rate of recurrence itself would increase with each episode of recurrence. Any layer of the epithelium or of the cornea can be affected by the herpes.
Dr. Arim, we can't hear you. Dr.
Maybe
Arim?
the connection break. Can you hear me now?
Yes.
Okay. Any layer of the cornea can be involved in this epithelium with the form of dendritic or geographical ulcer, stromal keratitis in its two forms, necrotizing and non-necrotizing, according to the above epithelium involvement, and endothelial keratitis. Both stromal and endothelial keratitis are the main types that are involved with the complications. A keratouveitis is a clinical picture of active corneal disease with anterior chamber inflammation. It can occur in association with any form of herpetic keratitis, mostly with stromal and endothelial types, as we mentioned. So why have I focused on IOP? Because it's a simple and preliminary measurement, basic, that we take in clinics, which could be a very important indication to other things occurring within the eye. As it could indicate the severity of the current keratitis. It could be an accompanying, it could be a sign of accompanying other tissue inflammation as anterior uveitis or trabeculitis. It could be a sign of anterior uveitis occurring on the background of previous recurrent keratitis. There have been many suggestions for the raise of IOP. The first is the occurrence of trabeculitis and the obstruction of the outflow by the swollen trabecular meshwork cells, the increased viscosity by the increased protein content, and a pupillary block due to recurrent anterior chamber inflammation. The two complications that of concern in my presentation are the persistent ocular hypertension, as more than half of the herpetic keratouveitis would develop an intraocular hypertension, with 13% of them that would persist, and a secondary open-angle glaucoma, which herpetic keratouveitis are mostly the leading type of uveitis that's associated with it. In a study by Sunger et al. Of patients with herpetic stromal keratitis, the total incidence of ocular hypertension was 47%, with 13% incidence, as we mentioned, of persistent elevated IOP during the remission period. In a retrospective study that was done by Falcon and Williams, they had patients who had elevated IOP associated with herpetic keratouveitis. All of them had a recurrent disease. None of them presented with primary disease. And those patients whose IOPs rose were more likely to have a concomitant uveitis. They have found too that those patients with fewer uveitic episodes, with less than 2 episodes, as in comparison to those who had more than 2 episodes, had a lesser risk of developing glaucoma. When studying patients who already had glaucoma as comparing to those patients who did not develop glaucoma, they have found that patients who had a higher number of IOP spikes and uveitic episodes, those are the patients who developed glaucoma. So we can say that a prolonged or recurrent inflammation may cause complications which can lead to secondary glaucoma and persistent high IOP. And in turn, the increased IOP provoked a significant rise in the risk of recurrence. It could be simplified by this illustration. A recurrent keratouveitis would lead to raised IOP with persistent ocular hypertension, secondary open-angle glaucoma, and this would increase the risk of recurrent, and a vicious cycle would be present. So what's the benefit of knowing all that? It's to direct us to the right goals of treatment. The first goal is to treat the current situation according to the findings. The current stromal or endothelial keratitis association of epithelial keratitis could be treated with topical acyclovir or steroid. The anti-glaucoma could be given in cases of raised IOP or anterior uveitis. Of course, not giving the which is the current situation according to the findings. And the second goal that we must pay attention to is to prevent the future episode of recurrence. As the herpetic eye disease study mentioned, a low dose of 400 milligram acyclovir 2 times a day would reduce the risk of recurrence. And this is our goal, as we have seen that complications are associated with recurrence mainly. So in conclusion, the elevation of IOP is a sign that should never be overlooked, as it may indicate recurrence, the development of more aggressive complications, and can serve as an important diagnostic hallmark and a sign that predicts severity and recurrence in the future. My take-home messages is to pay attention to very simple underestimated clues as raised IOP. This might contribute to the early and right diagnosis. The early misdiagnosis of herpetic anterior uveitis is common, so we must pay attention. And the last is sometimes the signs are hard to distinguish, so we must have a high degree of suspicion. If we are suspicious, we might reach the right diagnosis early. Those are my reference, and thank you.
Thank you very much, Dr. Reem. We open the discussion now. Ustaz Dr. Yahya Salah. We cannot hear you, Ustaz Dr. Yahya. Please unmute yourself.
شكرا جزيلا دكتورة ريم. Nice presentation, nice language. It's an important topic. We see a lot of herpetic cases, but I want to ask you a few questions. One is, there is a difference between herpes simplex and herpes zoster in presentation. Does it make a difference in the presentation or the treatment later on? Can you hear me?
There are some differences. Yes, I can hear you. Can you hear me, doctor?
Yes, perfectly. But...
Okay. Yes, can you hear me now?
Yes, I can hear you.
Yes. Usually the presence of herpes zoster would come with herpes zoster ophthalmicus, which would be associated with the rash. For the corneal association, stromal and endothelial keratitis is similar. The outcomes are also somehow similar. The herpes zoster is mostly associated with immune deficient patients, and it could be more catastrophic to the eye than herpes simplex.
And as regards treatment, you mentioned 4 milligrams of acyclovir.
This is mainly for the herpes simplex.
Yes, and for the zoster.
I think it's also for the herpes zoster.
No, you in herpes zoster, if you have only acyclovir, because others like ganciclovir are not available everywhere, but for acyclovir you will use 800 milligrams for a longer period of time, and you can taper it for 2 months, 4 months according to the condition. And of course, your presentation.
The herpes eye disease study mentioned that it could be for 18 months.
Correct. According to the progression of the disease, of the case. And one thing also in the treatment, you didn't mention anything, as you talked about the stromal keratitis, anything about steroids.
Yes, it's because the time is short. The main treatment for stromal and endothelial keratitis is steroid, even for the anterior uveitis. We give the antivirals either if there is an epithelial defect or if we wanted protection for the epithelium. If there is an associating uveitis, the steroids also are the main treatment. We could accompany it with oral acyclovir or oral antibiotics.
Correct, and you mentioned also in treatment of stromal keratitis that the use of topical antiviral. I think topical antiviral has no role in the stromal keratitis.
It only has one role if it's a necrotizing type with an association of epithelial defect, or in long use of steroid for patient with previous recurrent epithelial keratitis for the fear of recurrence of epithelial keratitis, just as a protection for the epithelium, not a role for the stromal keratitis itself.
Okay, of course, because of the concise time, you touched over the herpetic ulcer. You showed examples, and it is common, but what is more common we see, do you have an idea about combined infections and how this can affect the treatment and the progress of the case, improvement of the case? Like you have a case coming for you with pain in the eye ulcer and you see it as a fungal or bacterial infection. Is there something in the history that is important to lead you that it is a combined infection, and probably it has a herpetic or a viral component also that it has to be addressed so as the patient improves? Because usually these patients will come to you after 1 month or 2 months even with treatments of antifungal and antibacterial with no improvement. What do you have to say about this?
Maybe I would test the cornea sensitivity if this could lead us to some measurement, and maybe we could do a corneal scraping for a patient with a long duration. We do not use corneal scraping usually because it takes long time to give the results for. But for a patient with a long period, maybe we'll do a corneal scraping.
But scraping will not give you the diagnosis of herpes. The scraping, and you culture it usually to get a bacterial or fungal. To detect herpes, you have to do a PCR. But my point is just I want to highlight is that corneal sensation is very important, as you mentioned, and history. You say it is typical of recurrence. So usually this patient, if you ask him, he will tell you that he used to get a red eye frequently. Every few years he gets a red eye, some problem, and then heals. So if you have this history and you test the corneal sensation and you have an indolent ulcer, then with the antifungal or antibacterial infection according to your clinical suspicion and the scraping, the culture results, you should give systemic antivirals, and you will be surprised how many patients have this combination and how many patients will improve by you getting into the right diagnosis. Last thing, if I'm not taking too much time, is what's the major differential diagnosis of a herpetic ulcer, which is very important, and we see it a lot in our zone of the world. What can mimic a herpetic ulcer, but it's not herpes? It will appear like dendrites and dendritic ulcer. Dr. Reem, can you hear me? I don't think she can hear me, but this is acanthamoeba keratitis. Just for the audience to know, acanthamoeba keratitis, this is very deceiving. And if you are very rapidly just seeing the cornea and you see this dendritic appearance, you will say this is a herpetic ulcer. You treat as herpetic ulcers, and in 1 week, you will start to see typical appearance of acanthamoeba. So put it in mind that acanthamoeba
can you hear me now?
Acanthamoeba can mimic corneas. Thank you very much, Dr. Reem.
Thank you very much, Ustaz Dr. Yahya.
Thank you.
Yeah, Dr. Muhammad Al-Aqaba, please.
Thank you very much. A very interesting and important topic in the field of cornea and anterior segment. I really highly appreciate the comments by Dr. Yahya, all valid comments, important practical information. I just want to add a few points. First of all, with regard to the cause of high IOP and herpetic eye disease, as you mentioned in your presentation, what you would see in recurrent disease is more and more signs of consequences or complications like high IOP. But we have to be careful. It's in these cases, we tend to use a steroid, and a steroid is one of the important reasons why some people get high IOP and eventually secondary glaucoma. So you have to, in these cases, you have to use a weaker steroid to keep the disease under control, and also to keep the pressure as low as possible. So you have a fluorometholone or prednisolone 0.5%. It's commonly used in more controlled cases to keep the disease under control. The other important factor is measuring the intraocular pressure in these cases. So when you measure the pressure, you have to take the corneal status. What I mean by the corneal status is if you have
if we have an epithelial keratitis, we could use a non-contact method.
Absolutely, that's one thing. But also, if the cornea had multiple episodes affected by multiple episodes of herpetic corneal disease, then you end up with a scar tissue that will change the rigidity of the cornea. So you might end up with overestimation of the pressure, or if the cornea is thin, it tends to underestimate the pressure. So you have to take these.
We can use a transscleral method. Yes, the Goldman is the standard, but we could use the transscleral method.
Yeah, I mean, there are different ways also of measuring the pressure, but still in acute cases, sometimes you get, as Dr. Yahya mentioned, you can get a combined infection like viral and then ended up with secondary bacterial infection. And this is really an important point to our junior colleagues when they see these patients. Most of the time they focus on treating the corneal abscess or infiltrate, and they forget to measure the intraocular pressure. And we do see it sometimes. The infection is getting better under control, but when eventually after a few months, when you examine the patient, you could see a really pale cup disc from untreated high IOP as a result of a trabeculitis or secondary glaucoma. So these are the points I wanted to mention.
Thank you very much, Dr. Muhammad, for the very valuable comments, and as well, Dr. Yahya Salahuddin. And of course, thanks to Dr. Reem for the nice presentation. So now we move to speaker number 7, Dr. Ashjan. She will talk about oral ulcers, and Ustaza Dr. Mervat Shabrawi will discuss with you. Will you please start sharing your screen? And yes, we can see it.
You can hear me?
Yes. Bismillah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, my dear professors, for their valuable time. My talk, I am Ashgan Muhammad Asad, MD candidate in Cairo University. My talk in oral ulcers, not only patient. On 3 November 2023-22, 20 years old male patient was referred to uveitis clinic with left eye redness and diminution of vision of 2 weeks duration, history of oral ulcers and GIT symptoms of 5 weeks duration, weak history of skin allergy at 8 years of age, no history of arthritis or back pain. His best corrected visual acuity was 1 on the right eye, 0.4 on the left eye, the IOP was 10 on the right eye and 13 on the left eye. The left eye showed KBs, and the anterior chamber showed KBs on the left eye. The anterior chamber showed normal depths and cells plus 0.5 on the right eye, irregular depths and cells plus 3, flare plus 1 on the left eye. The pupil showed nasal posterior synechiae on the left eye. There is iris pigments on the anterior capsule bilaterally, but there is fine posterior subcapsular cataract on the left eye. The fundus showed blunted foveal reflex and mild hyperemic optic disc on the left eye. OCT macula of the left eye demonstrated epiretinal membrane with vitreomacular adhesion, and fluorescein angiography showed optic nerve head staining on the left eye. The patient was referred as a suspected patient because of oral ulcers and acute anterior uveitis of the left eye. The main complaint was painful oral lesions as shown in these photos. Differential diagnosis of oral ulcers include number 1, Behçet syndrome, inflammatory bowel disease, Reiter's syndrome, and disease are the main 3 causes of oral ulcers associated with acute anterior uveitis. Other differential diagnoses include infections, viral, bacterial, fungal, abscess stomatitis, neutropenia, acute necrotizing ulcerative gingivitis, drug reactions, contact allergy, and trauma. Primary management was by routine laboratory workup, immunology and gastroenterology consultation, upper GIT endoscopy and colonoscopy were ordered by the gastroenterologist. HLA typing couldn't be afforded. Topical steroid and cycloplegic treatment was prescribed. His laboratory investigation showed marked leukocytosis and with absolute neutrophilia and lymphocytosis on the CBC. Other laboratory investigations were unremarkable. Upper GIT endoscopy was done and showed mild gastritis, duodenitis, and erosions, and histopathology and H. pylori testing was recommended. Colonoscopy was diagnostic and showed severe extensive inflammatory bowel disease, most probably Crohn's disease. Treatment was started by topical prednisolone eye drops 6 times per day with gradual withdrawal, cycloplegic eye drops 3 times per day, systemic cyclophosphamide therapy. On 5 March 2023, after about 5 months, 5-month duration of follow-up, the right eye was normal with no abnormality detected. The visual with the correct visual acuity was 1, and there is no activity. The left eye was improved, and the best corrected visual acuity was 0.8, and it was 0.4 previously. The cornea became clear, and there is no activity on the anterior chamber. The pupil was festooned with posterior synegia, iris pigments on the anterior capsule, and the fine posterior subcapsular cataract were removed. Inflammatory bowel disease is a chronic inflammatory GIT disorder of unknown etiology. Includes ulcerative colitis and Crohn's disease. Both are characterized by episodes of recurrent acute attacks of rectal bleeding, diarrhea, abdominal pain, weight loss, and low-grade fever. Similar clinical presentations can oftentimes make it difficult to differentiate between both entities. This table shows the difference between Crohn's disease and ulcerative colitis as the pathological features, gross features. The more important is the involvement, which is non-continuous with escape lesions on Crohn's disease and the continuous involvement in ulcerative colitis, and the site of inflammation involves any part of the GIT common signs, terminal ileum and ascending colon in Crohn's disease, but it's present only in the rectum and the segmental colon in the ulcerative colitis. Other microscopic features that the extent of inflammation was transmural in Crohn's disease and involves only the mucosa and the superficial mucosa in ulcerative colitis. This photo showed the extent of inflammation, which is patchy and throughout the small and large intestine in Crohn's disease, and the continuous and uniform inflammation in the large bowel present in the ulcerative colitis. There is no difference in age of onset or symptoms in both diseases, but the Crohn's disease is more common. Malnutrition is more common in Crohn's disease, and blood stool is more common in ulcerative colitis. This diagram shows the difference between ulcerative colitis and Crohn's disease according to the location of inflammation, pattern of inflammation, the appearance of inflammation, location of pain and bleeding as previous, but the location of pain is typically in the lower left abdomen as ulcerative colitis, and typically in the lower right abdomen in Crohn's disease. According to the review published in the World Journal of Gastroenterology, ophthalmic manifestations in patients with inflammatory bowel disease were episcleritis, uveitis, and scleritis. Episcleritis is the most common ocular extra-intestinal manifestations, and seemed to be more associated with inflammatory bowel disease activity when compared with other ocular extra-intestinal manifestations. In IBD patients, anterior uveitis has an insidious onset. It's long-standing and bilateral and not related to the intestinal disease activity. Ocular involvement is more prevalent in Crohn's disease than ulcerative colitis according to the review of literature. Extra-intestinal manifestations of inflammatory bowel disease most commonly involve the skin, joint, eyes, and hepatobiliary system. The incidence of ocular complications has been reported to range from 4 to 10%, occurring more often in Crohn's disease than ulcerative colitis. These include conjunctivitis, episcleritis, scleritis, marginal keratitis, anterior uveitis, retinitis, retinal vascular occlusive disease, optic neuritis, and orbital inflammatory disease. Ocular involvement may either precede or follow the diagnosis of inflammatory bowel disease. In our case, the patient is presented with acute anterior uveitis, and we discovered this inflammatory bowel disease after good history taking and examination and consultation. IBD-related uveitis, the typical presentation is an acute anterior uveitis, typically the non-granulomatous form. Though IBD can manifest with a posterior or benign uveitis, anterior uveitis doesn't usually correlate with the active bowel disease. It's commonly associated with the skin findings of erythema nodosum and arthralgia. There is a well-established association between Crohn's disease, sacroiliitis, and acute iritis. These patients tend to be HLA-P27 positive. Take-home message: sometimes we need to think outside the box. Not all oral ulcers in young and middle-aged males are due to Behçet disease. Good history taking, systematic examination, and establishment of differential diagnosis are the best ways of getting the final right diagnosis. multidisciplinary approach and teamwork with other medical specialists such as immunology and gastroenterology are indispensable for good diagnosis and management. These are our references. Thank you.
Thank you very much, Dr. Ashjan. Now we open the discussion. Ustaza Dr. Mervat.
Thank you very much, Dr. Ashgan, for this nice presentation. Actually, I would like to ask you about the correlation or relation between GIT symptoms and anterior uveitis or uveitis. What do you think? Is it bowel? You explain expressively about irritable bowel syndrome and Crohn's disease, and to think outside the box, you have to think in another differential diagnosis. What do you think?
All non-infectious collagen diseases can such as systemic lupus erythematosus or that affect the small vessels or cause vasculitis, can cause gastrointestinal vasculitis and cause symptoms. Behçet disease also cause gastrointestinal symptoms. The uveitis case is a puzzle. يعني احنا we should take good history taking and the history and examination and accordingly the investigations that we require, all these things will lead to the diagnosis.
Okay, can I tell you something? We are going
Yes.
to go non-infectious. You speak about now about the non-infectious. Okay,
Yes.
if you are going to infectious one in GIT, what do you think? Which diagnosis can lead to similar symptoms and signs, not signs, just symptoms like that? Just to think.
H. pylori, I think, or I
What
know with
about parasitic infestation, Dr. Ashgan? Let me help you. What about parasitic infestation? Like ascaris, ankylostoma, you know?
yes. حاجة دوزن اللي هي DUSN بتعمل give retinitis in the eye and vasculitis.
No. Just toxins of these parasites can lead to anterior uveitis, immunologic reaction. Toxins. You know that uveal tract is a highly vascular layer of the eyeball. So toxins migrate to the eye and make or starting immunological reaction in the eye. Very common and very common to see oral ulcers, not Behçet syndrome, just oral ulcer with immunocompromised child or immunocompromised adult with parasitic infestation. Just to put in your mind to think outside the box. Okay. What other you speak about the immunological lab work. What other types of investigation you need?
For a case of acute anterior uveitis? Anterior chamber tab for PCR لو أنا if I suspect viral infection or other masquerade infections, masquerade as tumors or metastases. HLA typing is very important in acute anterior uveitis.
If you just, to cut short, if you just to think in a systematic way, you have to take a very good history from the patient. And going to have many directions. Lab work, radiological work, which is not mentioned at all in your presentation. And
for TB and sarcoidosis, chest X-ray, CT scan for chest.
You have to fulfill all investigations to help yourself, not to think in one direction. You have to think, especially uveitis, you know that, because you may go to every specialty or subspecialty of ophthalmology through this uveitis.
Okay.
Just to think about that. Thank you, Dr. Ashgan. Thank you very much, and wishing you all the best.
Thank you, Dr. Amelva. Thank you very much.
Thank you very much, Ustaza Dr. Mirvat, for the nice discussion. It's always a great honor to have you on board. And thanks for Dr. Ashgan for the nice presentation. Now we move to the last but not the least, Dr. Lamia. She will talk about nystagmus, and of course, nobody can discuss you better than Ustaz Dr. Ibrahim Adawi and Dr. Tariq Dais. So would you please start sharing?
Just a minute. Is it right?
Yes. يلا بسم الله.
Wait a minute. Just wait a minute, Doctor. Okay. Bismillah. Good evening. Thanks for all panelists and our colleagues. I'm Dr. Lamia Jamal Hamdi from Yemen. It's my privilege to be here tonight to share with you my presentation about nystagmus. I did choose this subject due to horrible thoughts about nystagmus for me and other colleagues. Therefore, I decided to search and collect ideas and points about nystagmus to ease this topic, which I finally found it easier than I think. So starting with the nystagmus definition, doesn't turn. Does it turn?
No.
What about now? Okay.
Yes. Now.
About nystagmus definition is a repetitive involuntary movement of the eyes. The eyes are unable to maintain fixation, leading the eye to drift away from the target of fixation. Three normal mechanisms to maintain foveal fixation of an object: ocular fixation, vestibulo-ocular reflex, and the neurointegrator, which is a network connecting between the cortical center, cerebellum, vestibular pathway, and extraocular motor neuron. The main function of the neurointegrator is a gaze holding, so any defect of these three mechanisms can lead to nystagmus. As any ophthalmic case, the nystagmus evaluation is starting with a history. Onset of nystagmus, a family history, systemic, including auditory and neurological manifestations, besides ocular manifestations, headache trauma, and drug uses. Then full ophthalmic examination, visual acuity, refraction, tension, ocular motility, pupil reaction, anterior posterior segment examination. And finally, the nystagmus description. So each type of nystagmus has its own character and give information about the site of the lesion. There are 7 points to describe any type of nystagmus, starting with the direction. Nystagmus can be horizontal, vertical, or torsionally. Conjugate when the both eyes are symmetrical and the direction, waveform, and amplitude of a nystagmus. Disconjugate when the both eyes are different in the direction of the nystagmus, while dissociated when both eyes are different in amplitude while the direction is still same. Two types of the waveform, either pendular or jerk. As shown in this video, the pendular looks like a pendule with 2 slow phases and no fast phase. So the refoveating period is between the 2 slow phases. The other type is the jerk, is as shown in this video. Slow phase followed by the fast corrected phase. So when we describe the direction of the nystagmus is according to the direction of the fast phase. So the right jerk nystagmus, when the slow phase is to the left, while the fast phase is to the right. Next, the frequency is the number of oscillations per second, either slow, moderate, or fast. About amplitude is the maximum extent of the nystagmus. Can be fine about 5 degrees, or moderate from 5 to 15 degrees. Or large, more than 15 degrees, or can nystagmus extend to the canthus. The null point or the rest is the site of gaze where nystagmus intensity decreases. In this site, the vision is good. Some patients associated with abnormal head position, as shown in this photo. This is occurred due to when the null point is not in primary position. So how can I remember these descriptions in a simple way? By dwarf. Dwarf is a mnemonic. D for the direction of the nystagmus, W for waveform, A for amplitude, R for rest, which is null point, and F for frequency. Nystagmus can be classified into physiological and pathological type. Physiological type, either optokinetic nystagmus or endpoint of vestibulo-ocular nystagmus. Pathological can be congenital infantile nystagmus, spasmus cutaneous, or latent nystagmus. About acquired, there are many types of acquired nystagmus. I only choose these types to describe them with videos. So starting with the physiological nystagmus, the first type is the endpoint. It is conjugate, jerk, symmetrical. Small amplitude when the patient see for long time to extreme gaze, leading to spontaneous refixation of the eye to the primary position. This can physiologically occur in old patients due to degenerative impairment of the neurointegrator. The other type is the optokinetic response, as shown in this video, by using the optokinetic drum, either horizontal or vertical. The slow phase will be in the same direction of the rotated drum, while the fast phase is in the opposite direction of the rotated drum to refixate on the next target. The vestibulo-ocular reflex is the movement of the eye that keeps the image stable on the retina during the head rotation. This is controlled by the three semicircular canals of the inner ear, either lateral, anterior, or posterior semicircular canals. So at the end, the eye movement will be opposite in the direction of the head movement. Two types of the vestibulo-ocular reflex, either caloric or posterotary nystagmus. The caloric by using water injected to the ear. For example, when we inject a cold water about 30 degrees Celsius to the right ear, so the direction of the fast phase will be opposite, which will be to the left. When we inject the right ear with the warm water about 44 degrees Celsius, so the direction of the fast phase will be in the same side of the injected ear, which will be to the right. The other type is the posterotary nystagmus, conjugate jerk nystagmus after prolonged body rotation. The fast phase is opposite to the direction of the body. The congenital infantile nystagmus. To remember the characteristic of this type, we use the word congenital. C for conjugate nystagmus and decrease in conversion. O for ocelopsia, which is absence in the congenital nystagmus. Ocelopsia means the patient see the object moves. And null point. G, gaze unipolar, which is horizontal nystagmus in all gazes. Left, right, up, or down gaze, it will be horizontal nystagmus. E for equal amplitude and frequency. And near vision is good. I, inversion of optokinetic response. T, turning of head toward the null point in abnormal head position. A, approaches and decrease in sleep. And finally, the L, latent nystagmus, may be present. This video shows the congenital infantile nystagmus. I add the description to the video. So it is conjugate, horizontal, with low amplitude in both eyes, horizontal, and unipolar in all gazes. To the right, left, up, or down, it is horizontal. The next type is the spasmus cutaneous. Characterized as this video shows, characterized by high frequency and low amplitude nystagmus, which is called shimmering. So the patient is associated with abnormal head position and head nodding as a compensatory mechanism to increase the visual acuity. The lesion either idiopathic or optic nerve glioma if associated with relative apparent pupillary defect or the disc pallor. So this patient needs neuroimaging. The final type of the congenital nystagmus is latent nystagmus. As shown in this video, there is no nystagmus in the primary position and using binocular vision. After we occlude one eye, the nystagmus will be jerk, horizontal. The slow phase will be toward the covered eye, while the fast phase away from the covered eye. So my advice for this patient is to measure the visual acuity using a filter lens instead of occluder to prevent the induction of the nystagmus. The gaze effect nystagmus is a pathological form of the endpoint nystagmus. As shown in this video, it is horizontal, jerk, absence in the primary position, and increase in the lateral and up gaze. So it occurred due to weak neurointegrator, and the slow phase toward the center, while the fast phase is to eccentric gaze. The lesion either brainstem or cerebellum due to stroke, tumor, or demyelination. The vestibular nystagmus either peripheral or central type. The peripheral nystagmus, according to the site of the lesion, it will be in the vestibular nerve or the semicircular canals of the inner ear, while the central it will be in the vestibular nucleus and the brainstem or the cerebellum. The auditory manifestation will be common in the peripheral nystagmus, while neurological manifestation is common in the central. The symptoms regress with time in the peripheral type, while be permanent and chronic in the central type. About the nystagmus characteristic, I will describe it in this photo. The peripheral nystagmus, it is unidirectional. That means only to the left only or to the right only. The nystagmus is improved with the visual fixation, and the nystagmus is the fast phase is away from the site of the lesion because of the normal brainstem to correct the phase, While the central nystagmus, it is bidirectional. That means to the left in the left gaze and to the right with the right gaze. It's not improved with a visual fixation, and the fast phase is toward the side of the lesion. This type, the upbeat nystagmus, it is a vertical type. Shown in this video, it is vertical, jerk, conjugate. The slow phase is down while the fast corrected phase is up, similar to its name, upbeat. This patient is complaining of the vertical oscillopsia, which means this patient see the object moves up and down. So when we see this type of nystagmus, we think about lesion in the posterior segment, either brainstem or anterior cerebral vermis. We do for this patient MRI if it is normal. Think about vitamin B1 deficiency, called Wernicke encephalopathy, characterized by nystagmus, ataxia, and confusion. The other type is the downbeat nystagmus. It is vertical, jerk, and the slow phase is up while fast corrected phase is down, similar to its name, downbeat. The lesion at cervicomedullary junction, most commonly Arnold-Chiari malformation. This photo shows the comparison between the normal brain and the Arnold-Chiari malformation. In normal brain, the cerebellum is in its place, while in Arnold-Chiari malformation, the cerebellum is herniated through the foramen magnum. So patient needs an MRI if it is normal. Think about vitamin B or magnesium deficiency. Other causes including drug toxicity, stroke, demyelination tumor, or trauma. This video shows the downbeat nystagmus. It is conjugate, vertical. The slow phase is up while the fast corrected phase is down, similar to its name. The last type is the seesaw nystagmus. It's same to the action of the seesaw playground. So as shown in this video, it is disconjugate, torsional, pendular. One eye is up and entorted, the other eye is down and extorted. When we see this type of lesion nystagmus, think about lesion in the chiasmal part, either paracerial tumor due to cranopharyngioma or pituitary adenoma, or ocular disease as a retinitis pigmentosa albinism. This patient needs neuroimaging at the visual field. The visual field result is bitemporal hemianopia. So my take-home message is not all nystagmus is pathological. Physiological forms are also presented. If pathological nystagmus, think about lesion in the cortex, cerebellum, or vestibular system. Dwarf is an easy way to remember how to describe any type of nystagmus. So please don't escape from any case of nystagmus because it's easier than you think. Those are my references. Thank you for your attention and your time.
Thank you very much, Dr. Lamia, for the nice presentation. Now we open the discussion. Ustaz Dr. Ibrahim Adawi, please.
Assalamu alaikum. Thank you very much, Dr. Lamia, for this nice presentation and the courage you can present such a tough subject. Everyone want to escape from nystagmus and extraocular motility. But you simplified the topic. I ask you in your presentation in congenital nystagmus, you mentioned mnemonic congenital.
Yeah.
Yes. I think from where you get this mnemonic?
There is a slide from SlideShare and also from application called Pinterest. Also, a doctor, neuro-ophthalmologist from YouTube, describe the nystagmus well.
Okay.
I add in the references, doctor.
And spasmus nutans, which is very common. Spasmus nutans.
Yes.
You mentioned the triad. You don't write it in the slides, but you mentioned it in your presentation, which is the torticollis, nystagmus, and
head nodding.
Head nodding.
Head nodding. Yes.
Why torticollis? Why torticollis and head nodding occur in such case?
Because of they are a compensatory mechanism to increase the visual acuity. Also, the patient nystagmus will increase in the abduction. So the patient will come in torticollis, with torticollis.
Very well. This is a compensatory mechanism to improve the vision by reducing frequency and amplitude, both frequency and amplitude of nystagmus. What about the prognosis?
About spasmus cutaneous.
Yes, spasmus cutaneous.
Yes, first, it occur in the first 2 years of life, but it's common to regress with time by the 3rd or 4th year of life, and rarely
Yes.
at the 8th year.
Yes, yes. This is has very good prognosis, spasmus
Prognosis,
recurs,
yes,
and you have
yes.
to reassure the parents about the child. It will disappear.
Yeah, and the head
Uh,
nodding will disappear, and the abnormal herpetization will disappear with time.
what is the difference between endpoint nystagmus, which is physiological, and the gaze-evoked nystagmus, which is pathological?
The endpoint nystagmus occur due to weak neurointegrator, but the patient is by its way seeing to extreme gaze. So the patient not all the time see to the extreme gaze, and normally it is to primary position. By the nystagmus characteristic, it is symmetrical and small amplitude, and not for large angle. While the gaze epoch nystagmus, it's occurred due to weak neurointegrator. The patient will see to the gaze for a long time, but he can't hold the gaze for a long time. So the slow phase will be to the center, and he will do the fast phase to eccentric to hold the gaze and to hold the gaze.
Okay.
About the nystagmus characteristic, it is asymmetrical. It is persist. Yeah, it is persist a large amplitude more than 45 degrees from the gaze. It will appear and persist.
Yes. What about, you don't mention in the presentation the management of nystagmus, surgical management of nystagmus.
Surgical
what
management.
is the indication
okay.
of surgery in nystagmus?
If a patient associated with torticollis, abnormal head position, and the surgery is called a recession procedure or Anderson Castambion procedure. Yeah, for example,
mainly in null point nystagmus in order to straighten.
The aim is to shift the null point to the primary position to decrease the head torticollis.
Yes, especially if the null point in the right or the left gaze. Sometimes the null point in the primary position, no need for surgery at all.
Yeah.
Okay. In pendular nystagmus, not null point nystagmus, is there a role of surgery?
Sorry, endpoint.
In pendular nystagmus, no null point, no abnormal head posture, but some recommend some types of surgery as just to cut the medial and lateral recti and resuture again in order to decrease the
proprioceptus.
Yes.
Uteratomy.
Yeah. Thank you, Dr.
Doctor. Thank you.
Nice presentation.
Thank you, Dr. Ibrahim.
Thank you very much, Ustaz Dr. Ibrahim, for the nice discussion. And of course, it's a great honor to be with us always. Thank you. Now Dr. Tariq, please. We cannot hear you, Dr. Tariq, please.
Thank you, Dr. Lamia, for this nice presentation. Nystagmus is a complicated subject. You are presented at a simple manners. I have 2 questions. First one, what are the primary causes of acquired nystagmus in adult? If patient come to your clinic in adult and complain of nystagmus, what do you think about?
As I mentioned before, the nystagmus occurred due to defect in the 3 normal mechanisms, either ocular fixation or the vestibulo-ocular reflex or the neurointegrator. So the causes will be neurological, auditory, and other causes. The neurological may be multiple sclerosis, stroke, or brain tumor. The auditory can be vestibular neuritis, Meniere's disease, and a benign paroxysmal positional disease or vertigo. The other can be a drug toxicity or head trauma, alcoholism patient. That's it.
Beside the surgery, there is any specific lifestyle modification or visual aid that can assist patient with nystagmus?
Yes, if the patient if no benefit from surgery, we can use a low vision aid to help the patient for reading and close working. There are 3 types of the low vision aid, either optic as bioptic glasses, or electric or video magnifier, or that's it. Or can be glasses or contact lens.
Okay, thank you. Thank you, Dr. Mazen. Thank you, Dr. Lamia. Nice presentation.
Thanks to our panelists. Thanks.
Thank you, Dr. Tariq, as well for the nice discussion. At the end of this session, and this is the last session and the first episode, I would like to thank all the panelists, professors who spent a lot of their valuable time to support the young ophthalmologists and to give their experience, to transfer their skills and experience to the young generation, to carry to be the messenger, actually. And of course, many thanks for the participants who wanted to contribute to the iTeach program. And of course, later we will announce about the best presenters in the 4 sessions. We will select best 2 in each session. So in total, there will be 8 winners, let's say. And of course, it's very fair evaluation because we depended on a systematic way, checklist, and we are taking the evaluation of a number of the panelists who are attending with us. So thank you very much, everybody, for being with us. And of course, any presenter who contributed to the first episode can as well send their presentations for the next episode. So it is not, this is not the end, and we are waiting for more contribution from your side. Thank you very much, everybody, and have a good night. السلام عليكم ورحمة الله وبركاته.
Thank you. عليكم السلام ورحمة الله. شكرا دكتور مازن.
Thank you
very much.
شكرا جزيلا. عليكم السلام.